So my name is Joyce Lee. I'm a pediatric endocrinologist here at the U. And we do encourage you to come up. It's a little bit of a smaller group, unfortunately, because of Academy Health. We didn't realize the conflict, but we have super, super quality people in the room, like Dr. Campbell and Dr. Davis and Vina, one of our new faculty members, and the illustrious guests in the back. So we encourage you to come forward and actually have a conversation. We'll be doing he'll be doing another lecture tomorrow, and this is going to be recorded, so we'll allow members of our greater community to enjoy this work. So I have the great pleasure of introducing Michael Seid, who is a Ph.D. in psychology from the University of Illinois Urbana-Champaign. He is professor of pediatrics at the University of Cincinnati Medical School and director of health outcomes and quality of care research in the Division of Pulmonary Medicine, and director of chronic care research in the Anderson Center for Health Systems Excellence at Cincinnati Children's Hospital Medical Center. His research applies social and behavioral science to answer this very simple but extremely important question: what does it take to make the healthcare system work well for children with chronic conditions? Over the past 6 years, he's addressed this question as co-PI of the C3N project by designing and prototyping the first Commonsbased peer production learning health system, which began as a quality improvement collaborative called Improve Care Now, focused on children with inflammatory bowel disease. He and his colleagues now have proof of concept for the model and data on how this IBD-QI network has evolved to become a C3N, and they are in the process of furthering the development of this model, extending the model across pediatric institutions and PedsNet with PCORI funding, and replicating this model in cystic fibrosis and type 1 diabetes with foundation funding. I've had the great fortune of working with him and his team this year as we're trying to build a C3N for type 1 diabetes. So it's been a really exciting and collaborative and innovative process that has involved systems design thinking, design ethnography, quality improvement methods. I mean, just, the diversity and variety of people that have been involved with the projects has been really impressive. And I think, this is really the future of how we should be doing healthcare. So really excited to see you guys, one, tell us about what you've done in IBT, but two, help us spread and scale this across all of the diseases that need this. So it's my great pleasure to introduce Michael Seid. Thank you.
Thank you.
Okay.
Thanks, Joyce. That was a great talk. And I'll just elaborate a little bit on what Joyce was talking about, because, it's I should just say it's a pleasure to be here. Given that we have such a large audience, it'd be I will, tolerate hands shooting up, and it's great to have a discussion about this. I can go all the way through. I can talk ad nauseum about this stuff. So interrupt when you feel the urge to. I have no disclosures to disclose, which means that I haven't gotten any money for this yet. So here's the problem. We know from the literature that people get about half of the care that's indicated and do about half of what it takes to stay healthy. And if you do the math, it turns out that people are not getting particularly good health care or taking care of themselves. So in general, this is bad. And so we also did some in-depth research. Joyce mentioned the design ethnography that we did. So tell you this story from the people's point of view. This is Bianca, who's 10 years old and has Crohn's disease, and she's obviously in a lot of pain, but she also needs to know where all the bathrooms are. She can't go on sleepovers. The healthcare system's not working for her. Oops. This is her doctor, Sandy Roan. There was a previous picture of a Dr. Sandy Roan with paper charts, but we've upgraded. Now she's charting on Epic or whatever EHR that she's using. And the best evidence for Bianca's care comes from randomized clinical trials, which don't necessarily apply to Bianca. And so the system is not working as well as it could for her. This is Bianca's mom, whose name I forgot, but she understands that it's important to take her daughter to the doctor and follow along what's going on and follow the doctor's orders, but doesn't yet understand that she can be part of the team or what role she has to play. And this is Dr. Mitch Kapoor, who's a researcher who is trying to understand the natural history and epidemiology of Crohn's disease, and has a hard time getting records and samples, and so the system's not working particularly well for anybody in the system. So we asked in the beginning of this quest, what if we could create a vastly better healthcare system by harnessing the inherent motivation and collective intelligence of patients and clinicians? Why do we have half of doctors not giving, or doctors giving half of the care and patients doing half of self-care? It's not because nobody cares. It's not because we don't have good ideas. Everybody cares and has good ideas. What we don't have is a system for harnessing that inherent motivation and the collective intelligence of everybody living and working in the healthcare system. And what if the system allowed patients and physicians to share information, collaborate to solve problems, and use their collective creativity and expertise to act in ways to solve health? It's a little bit more personal story. My daughter was diagnosed about two years ago with Crohn's disease after I'd been working in Crohn's disease for a number of years, which is kind of an interesting twist of fate. When she was diagnosed, my wife had a lot of questions, and Claire had a lot of questions. What should we feed her? What medicines are right? What about her boyfriend? Maybe he's giving her a lot of stress, and maybe that's what's making the pain flare. That was my hypothesis. She had questions like, what does this mean for me? How do I tell my friends? And all this kind of stuff. And I said, I don't know what, but I know how to find out. And this, in essence, this question of what to do, we know what to do a lot of times, but we don't know how to do it. We don't know how to make sure the right child gets the right treatment at the right time every time. And that is really the essence of the problem that we're facing. And the thing is that health is a complex system. The health system is a complex system. It's full of people interacting with each other and with information and technology in the context of policy and regulation and culture. So the major task in improving the healthcare system is producing and coordinating information or data, knowledge, or innovation, and know-how, like how to actually do this. And we're inspired by this Institute of Medicine concept of the learning health system. And this is what the learning health system, is really talking about. It's one system for improving and doing research rather than the two we have now, or one, for clinical care and for research. And where data is generated, the point of care is aggregated into knowledge, and that knowledge is then fed back to the point of care. It's a very powerful conceptual framework. And then the question, that's cool, magic bug. The question is, who should be learning, and how should we organize this learning? The question is it experts that should be learning? Should we have everybody learn? And this is really the difference between Microsoft Encarta and Wikipedia. And some of us are old enough to remember Microsoft Encarta, which was Microsoft's attempt to come up with the world's largest online repository of knowledge. Bought Funk and Wagnalls, they bought Encyclopedia, or Grolia's Encyclopedia. They hired thousands of professional editors, and they had the weight of Microsoft behind them. At the same time, or a little later, Jimmy Wales had this harebrained idea. He's the founder of Wikipedia. Would have gotten laughed out of every business school he could have pitched this in, and that was that he would make it possible for any volunteer anywhere in the world to write about what they are passionate and knowledgeable about, and they would then aggregate all this knowledge together and create this online encyclopedia. Well, the rest of the story. The rest of the story is, if you Google Microsoft Encarta, the first entry is the Wikipedia entry, which says that Microsoft Encarta stopped production in 2009 because they couldn't get anybody to pay for their service in the face of this better free product. Not only did Wikipedia beat Microsoft Encarta, but at the time that Microsoft Encarta stopped production, they had 1.75% of all online hits for online encyclopedias, and Wikipedia had 97%. So this group of volunteers crushed this very large corporation. And this is Commons-based peer production. This is an example of Commons-based peer production. The idea, and Yochai Benkler is at the Berkman School of Society, Internet and Society. He's a constitutional law scholar, but he's written this book called The Wealth of Networks to describe this commons-based peer production. With the right system, everybody can contribute to the solution. So the question is, if we had a learning system that looked like Wikipedia, a learning health system that looked like Wikipedia, what would that look like? And that's the idea behind the Collaborative Chronic Care Network project, or the C3N project, is can we construct a commons-based peer production learning health system for transforming health and healthcare? So Joyce mentioned Improve Care Now, which is a network of now, these slides are always out of date because we're adding networks and patients all the time. There are now 76 care centers across the US and in the UK of clinics that treat kids with pediatric inflammatory bowel disease, Crohn's disease, and ulcerative colitis. Now there's about 600 gastroenterologists and a little over 20,000 IBD patients. And this was our first sort of prototype of this system. When Improve Care Now started in 2007, there were 7 care centers, and the rate of remission for kids in their practices. So if a kid with inflammatory bowel disease, if you're in remission, you essentially don't have any frank symptoms. You can live your life fairly normally. So the goal for Improve Care Now is remission. Went from about 60% to now almost, it's about 79%, with no new drugs. And the other amazing thing is at the time we started, no center had a remission rate over 80%. Now, about a quarter of centers have a remission rate that's over 80%. Again, no new treatments available for Crohn's disease. So how did this happen? How did they do this? Well, they did it by sharing. They did it by sharing information, sharing knowledge, sharing know-how, sharing the work of improvement. But what's going on here? There's what has really become, in retrospect, more obvious to us is that healthcare is a complex system, and what I mean by that is that it's a system in which the interaction among the people and agents within the system makes emergent behaviors. So I said, healthcare is a complex system, and so what we've tried to do is change the interaction among the parts of this healthcare system: the information system, the people, the policy, doctors and patients, and with a complex system, there's emergent phenomena. So this is a picture of a school of fish, but there's you can look at a flock of birds, with emergent phenomena, you can't describe the phenomena by describing the individual agents. So flock of birds, you can't describe by describing birds. What are the rules for flocking? I have them written down, actually. There are 3. Don't crash into your neighbor. Generally go in the direction your neighbor is going, and generally go to the place where your neighbor is. So those are the rules for flocking. And if you have those 3 rules in place, the individual birds create this emergent phenomena of flocking. And so with the idea of a complex system, we've been learning a lot about the architecture of these kinds of systems, and I'm going to talk a little bit about actor-oriented architecture and what we think is going on with this C3N with inflammatory bowel disease. So a note about architecture. Organizational architecture describes how decisions are made, how resources are allocated, and who gets to tell people who to do what. There's several types. This is the hierarchical architecture, right? You have the manager on the top, and then everybody kind of dribbles down. There's a more complicated hierarchical structure called a matrix architecture, where you have operational type people and then projects, and everybody kind of this is very common in multi-project organizations. And then you have the something else, the actor-oriented architecture, we'll call it right now, that allows people to self-organize. So what is the actor-oriented architecture about? You need three elements. First is the actors that have the values and capabilities to self-organize. So both the values and capabilities. There's a commons where actors accumulate and share resources. So when I find out something that works, I share that. And when somebody else needs to know what works, they can go to the commons and pick it out. And then there are structures, processes, protocols for facilitating multi-actor collaboration. So think about this in terms of Wikipedia. Who are the actors? Well, anybody. They say anybody who has edited Wikipedia is a Wikipedian. Cool. That's pretty neat. So and they're experts as well as amateurs. The commons of Wikipedia is Wikipedia itself, right? They've created this common pool resource of the largest online repository of knowledge in the world. And then the structures and processes and protocols, you have a wiki, right? The web site that enables this accumulation of knowledge. You have norms. You have ways of becoming a leader and an editor. You have trainings, all kinds of things. But health is different. Healthcare is different because we're not all Wikipedians. We have different roles. So let's go through these different parts and see if we can't understand a little bit more about improved care now. Yes, Matt.
I could just raise a point here.
Yeah.
What's really already emerging here is that I think many folks in medicine thought we already had an actor-oriented architecture in terms of all the providers caucusing together at annual meetings and sharing insights about how to take care of patients better. And,
right.
oh, we do this at our institution, why don't you try it at yours?
Yeah.
And that sort of thing. And that just wasn't doing it. It was really the wholesale change to accept the patients themselves and their caregivers into this architecture, which has been transformative. I think to me, that's what sings out of your model, is the transformational change is actually making an equitable participatory model work.
Yeah. I think that's right. I think that's a nice characterization. And the other way of saying it too is that patients are also sharing experience, like with each other on the web or in the clinic waiting room or wherever. But what hasn't happened is the doctors and the patients haven't gotten together to connect and share. So yeah. And you're right. The medical conference is a place where we can do this once a year for a couple of days.
But that's not a commons, and that actually
It's-
is a culture that doesn't cultivate the equitable relationship between, right, like providers and patients, right?
This is true.
So,
Yes.
right.
Yeah. So you're right. I'll just keep going. Keep jumping in. So the actors with values and capabilities. First, talk about the values. One of the things that we established very early on with Improved Care Now is what is it that we're trying to change? What is our common purpose? And I mentioned remission. Right? This seems kind of obvious at first, but it took a little while to decide that across all of the work that we're doing all together at all of these sites, the one thing that we're going to measure that's the same everywhere, and we're going to measure it the same way because that's what we care about, is remission. How do we measure remission? Is that the right measure? All that, because that's a social process to come up with this common purpose. And then, there's a certain type of leadership that is required for this kind of peer production. Peer production is essentially voluntary in some ways. That means that you can't tell people to share. It's like Margaret Thatcher said: if you have to tell people you're a lady, you're not. So, so how do you get people to do stuff without telling them, without the authoritative, or authoritarian, means to do so? There's leadership in that, and then an expectation that everybody should be actively involved. This becomes a norm, and it's very interesting to me, having worked with Improved Care Now for a long time. We started with only clinicians involved, and we added patients and parents. But the newer care centers, they don't know any different. They figure this is the way it is, and so they're scrambling to get patients and parents involved. And they're like, "This is great. We're going to." The older centers are still kind of coming along a little bit, but now there is this active, this expectation, like this is how we do it. We work with patients. If you look at the Improved Care Now culture, there are several different ways, and I will kind of talk a little bit about them, how Improved Care Now propagates this culture. But it's all teach, all learn. The credo is steal shamelessly and share seamlessly. If you ask anybody in Improved Care Now about, steal shamelessly and share seamlessly, they'll say, oh yeah, that's exactly right. Because if you have a good idea, you share it with me. If I have a good idea, I share it with you. If I see something, I'll take it because we're all in this together. It's a common commitment to the collaborative, and then you can make a difference. It's a personal sort of we are all part of this thing, and you individually can make a difference. This is what happens. We ask people to just sort of describe Improved Care Now. These are the kinds of things that come up. So culture, it's a common purpose, it's leadership, it's expectations, and norms building that we have developed, and then the capabilities to self-organize. Now, a lot of people have a lot of inherent skills. They have the things that they come with. That's the third point. But we've also been teaching people how to do this a little bit better. We've been teaching people how to do community organizing. So we're working with people who have, and this is Ann Arbor, so I can say people who are working with the Obama campaign for 2012. They were the sort of ground game for Obama 2012, and are helping us kind of create a distributed leadership organization where you have essentially local field offices that recruit people, and then the local field offices report up to the regional field offices in the state, but it's a way of identifying, recruiting, and organizing volunteers and growing leaders at the local sites. Co-production is really the idea of working with your patients, not for your patients. And that is a fundamental mind shift, but it's also something that both patients and clinicians need a little help to kind of navigate. So if we're trying to get parents and clinicians to work together on quality improvement teams at the care centers, but we don't want the parents to come to the table, to the quality improvement meetings and sit around the edges of the room. We want them at the table. And if they are calling their doctors, Dr. So-and-so, but they're being referred to by their first name, does that make a difference? Or how do we negotiate this? So there's a whole set of learnings that one can one can put together to teach about how to do this. And then recognizing what people bring to the table. One of the things that Wikipedia recognizes, everybody's an expert in something. And this is the case in every situation. Everybody's an expert in something. So who are these people? Well, Jill was the first leader of our patient advisory council, and she helped us design the C3N. She was part of the first meeting, the second meeting. She's now in graduate school, but she still comes back to the community conferences, and this is why she participates. The last one is really interesting. I don't want other young people with IBD to feel as if their care is beyond their control. So people are generous sort of by default, many people. And this is what and there's a lot of social and anthropological and biological and cultural research to show that, there are sociopaths, there are good Samaritans, but by and large, most people are pretty cooperative, pretty generous, and you can actually design for that. So you give people the opportunity to participate, and they will. This is our, some of our PAC members, and these, when we, when you look at these guys, they're young kids, right? But ask them what they wanted to do, and they'll tell you, we want to help design, we want to provide leadership. They're telling us all of these things that they have, that they want to offer to us. The parents that we're working with are smart enough not to wait. They told us, here's what we do. Put us to work. We're a pretty good bunch of people. And we started looking at this list and went, wow, there's a lot of things here that we can take advantage of. So, figuring out ways to work with hedge fund managers and media consultants and business developers and meeting coordinators, VP of new technology. This is a lot of good stuff that we can bring to bear, and they want to contribute. So those are the actors. And then, the second element of this actor-oriented architecture is the commons, where actors accumulate and share resources. So what are we talking about? We're talking about sharing clinical data across care centers. We're talking about sharing sort of know-how, the sticky knowledge of how to improve your own care center and what it is that we actually do when we try to do this new thing. And we're talking about experiences and learning and just like the conversations about what it's like to be a patient with a chronic condition that may not raise the level of even awareness from the provider's perspective. Things like, how do you travel with all the sharps that you need, or what do you do about your other kids who aren't sick and who might feel neglected, that you're spending all your time with this really sick kid? And these are the kinds of things. So we've created ways to make it easier for people to capture and share these bits of knowledge and information and know-how. The first one is about the registry data. We taught everybody to, like I said, everybody in Improved Care now has a population registry of all their kids. How do registries get populated? Well, this is traditionally what happens. You have a clinical encounter, and you chart that clinical encounter, and then you go through and you abstract that clinical encounter for the registry information, data points, and then somebody else comes and does data entry. This is a 3-step process. It's very slow, it's expensive, and it's really cumbersome. So what we developed was a way that you could do essentially data in once. You did the streamlined data entry where you have smart forms for Epic and Cerner and GE and other terms for this, but where you have the data that you need, all pre-specified and values pre-specified. It's not free text, it's discrete values. The extract, transfer, and load, there's a local I2, B2 instantiation, and it goes to a shared sidecar registry. So anytime a patient and doctor interact, the charted information goes to the EHR and to the registry. So now the data is in once. This just shows that. Here's the rate when we were starting to build and deploy this enhanced registry, the percent of patients with the data transmitted directly. And then we were able to, and I'll talk about a little bit later, if you have data that's available, that's translated, and that is transformed into clinical information, you can actually use it for quality improvement and clinical care. We have automated PreVisit Planning reports and population management reports. This is the data quality monthly report, but you can see that the data is pretty good. Why? Not because we pay clinicians to enter data, but because they use it. It's useful for them because it's used for clinical care. And then there's tools for making this sharing easier, both online and offline. The online tools that we've developed are the Improved Care Now Exchange, which is kind of like Pinterest, and you can actually pin a PDF or a Word file or a movie or whatever. And if people wanted to know, if you wanted to show people how we make sure every registered patient gives consent. This is the checklist that we use, pin it up there. Here's an information booklet that we use, pin it up there. Here's a tool, and then people can download and share and modify. And so it's a way to make the know-how flow. And then Smart Patients is a conversation platform for patients and parents that's has a very deliberately designed and implemented culture that's sort of pro-science, information-rich, very respectful, and so it's a way of sharing peer-to-peer learning. Then offline we have monthly phone calls, learning labs, and community conferences. This is just a graph showing the rate of use across the care centers for the ICN Exchange. So you can see pretty much all of the care centers are using this Commons platform to put information into the Commons pool and to take information out. Then the third element is this ways to facilitate multi-actor collaboration. So what does this mean? It's just, we have actors that are motivated and have the capabilities to self-organize, to solve problems. We have ways for them to share information, and then how do we make it easier for people to say, I have this issue, I want to work on it. Oh, I got some expertise about that. Let's work together. What do we do when we're actually working together? What are our roles? How do we decide who's leading, or how long this team stays together, and what the goals of the team are? And we've done this several ways, but I just want to point out the three here: automated PreVisit Planning and population management tools that I mentioned earlier are ways to facilitate the interaction among patients and clinicians in the clinic. The Orchestra platform is a tool for collaborative self-tracking. We also have an innovation process that is a way of actually taking ideas to actual tested prototypes, pilots, and scale up. And then this collaborative QI network is a way of organizing the learning across the whole system. That's a process that's pretty well standardized in Improved Care Now.
Can you give us
Yes.
I love what you're saying. It's very exciting. But it would help me if I had an example, a clinical example of something that wasn't being done before, and then as a result of all these, the structure,
That's what I think would help.
and it is being done.
Okay. So here's some examples of the clinical, the PreVisit Planning report. So PreVisit Planning is one of those things. The idea is, and I'm not a clinician, but I've heard about this, that every time a patient, that you could know who is coming in advance to your clinic and what was what their presenting issues were and what the status is, and therefore what to do. You could do pre-visit planning the week before for all the patients coming up. This is a nice thing. A lot of times what happens is you see the doctor take the chart off the door on the outside, and that's the pre-visit planning. It's not so good.
So it's something like maybe a certain percentage of patients were not taking their medications as they were supposed to be doing it, and yet as a result of this structure, a higher percentage were taking their medications as they were supposed to be.
So when we started, there was a. I remember I said that there was a consensus around remission rate as the outcome. So then the next question is, what are some of the things that we can do to change remission rates? And some of the very basic things that people wanted to do was, whenever a patient comes in, they should have their height and weight charted and documented. We should know where the disease is. Then that should be charted. They should be tested for antibodies before they start a particular treatment. And then one other thing that I can't remember, and they decided, the gastroenterologist decided, if you do all those 4 things, this is basic level of care. And so they did a chart review, and they said if you get all 4 of these right, you get a credit. If any one of them is missing, no credit. The hit rate was about 24%. So about a quarter of people, of clinicians across the network, were charting all 4 of these.
So maybe some of the patients were underdiagnosed as having active disease, and then once that was recognized, they could be treated more aggressively.
Right. So and so this is sort of process improvement, and when you change so that so now it's 99%. Everybody's got all of these pieces in their charts, and because they have the pieces in the charts, right, now you can make an informed clinical decision. You chart height and weight, and you've got BMI trajectory. Now you know the right dose. So that kind of thing. This is it. So is that helpful? Or it
just seems sort of remarkable that the percentage of patients in remission went up so dramatically, and I'm just wondering, to what do you attribute that?
Go ahead.
So I think that it's the standardized care at a certain level, right? So you get the basics right, and then being able to track the patients over time, to see their remission status at each point in time. Then you can start digging in using pre-visit planning and population management. You can say, like, who hasn't been in forever? What's going on with Johnny? We should get him in. Or you can say, this person, is coming in next week. They haven't been in control yet. And what are some of the things we've tried? Do we know everything about them? And you can actually start to have the data and the information in order to make those kinds of decisions. That's before we started actually even engaging the patients in improvement. And I think that's a lot of what is going on. And then I think there's a fair bit of, and this we have less data on, but I think there's a fair bit of knowledge that the patients bring about their own selves and their own, how their daily lives are and what their own symptoms are like. And I think having a more open conversation at the point of care about, like, what's going on with you, it sort of opens the conversation to that additional expertise, and you can start taking that into account as well. Now, which kind of leads to this next piece of what I was saying. This orchestra is this collaborative tracking tool. Now, this is not deployed widely, But it will, I think, help to facilitate that dynamic of like, what are we all here trying to do in this clinical encounter, and what can we try? Because right now, what happens is, you meet with the patient, and there's an indication for a treatment. That prescribing that treatment is essentially a single subject trial, right? That we have clinical, we have RCT evidence, but nothing that says anything about this particular person in front of us. So we, say, try this. It should work for you. Come back in 3 months. Tell me how it went. So the person comes back in 3 months. How'd it go? Pretty well. Do you take all your doses? Sure. Okay, let's maintain the dose. This is a single subject trial, but not a very great one. At the same time, patients are probably doing all kinds of single subject trials on themselves, right? Eating different things, trying to exercise more or less, yoga, acupuncture, whatever. And depending on whether or not you ask and what kind of relationship you might have with your patient, they may not tell you about this. So they're also doing parallel experimentation, but we're not doing this together in a rigorous manner. So we've developed this process and this technology platform that enables this collaborative self-tracking. And it's on a desktop, and it's on mobile and tablet. So you can get web-based queries, you can get SMS, text, and then you can, these are fancier slides than the previous ones. You can do symptom tracking and data visualization. Now, instead of coming back 3 months to how did it go, it went pretty well, we have a daily, how is your appetite, and well, this is headache severity, but essentially you've got daily measures now that you can look at. You can also do symptom surveillance. You can look for particular things that are out of range or out of control. You can have alerts happen. And then you can actually try some systematic planned experiments. So, let's try to change this antibiotic to something else. Let's try, adding this. And you can actually see when you start and stop what the difference is. And you can use this for PreVisit Planning and to get results back from like the lab and things like that. So this is a tool that we're piloting now. It hasn't been widely deployed, but we think that it'll actually make it a lot easier to do this kind of collaborative tracking. The third thing that we've done to kind of facilitate the multi-actor collaboration is this innovation process. We're developing new ideas all the time, and it's really fun and exciting to come up with new ideas, and anybody can do that. And then, kind of what happens after that, because if you don't have a process that's supported, it's less likely that these ideas will come to fruition. And so we have taught Improved Care Now how to do this process of design and prototype, pilot, and implement as a portfolio. And then this, so we had, as we were developing, we had a whole portfolio of innovations that all started at this design phase, and some of them actually went further to the prototyping phase, where we're actually trying it out in an artificial environment. Then the next stage is piloting, where you're actually trying it in a real environment, like in a real clinic, maybe in 1 or 2 clinics, to try to see if it still works under different conditions. And then you can actually move that along to scale them across different clinics. So it's a systematic process for learning as you go, from the idea to the actual thing scaled up. and then some of them, drop off. So we thought, Shrine would be a good thing, and it didn't work out so well. The nice thing is that you can actually look at an overall dashboard and see where all of the different innovations are for the whole system. So it's a way of, again, kind of systematizing this process. I will keep going. I know we only have about 10 minutes, but I want to just give you some examples of some of the things that have happened when we, enabled actors to self-organize, when there's a commons and ways to actually facilitate this multi-active collaboration. We started working with families. They are now teaching us at the learning sessions at this community conferences. They're doing panels. They've created booklets for parents. There's a parent handbook that was posted to the exchange. They're solving problems that we don't even know are problems. They're presenting us solutions to things we didn't even know were problems. So this was a parent at Riley Children's in Indianapolis who said, you know what, it would really help to have everything organized. Good. That's great. And so she created a binder with all these different tabs and what you should look for, and scanned it in and posted it on the exchange. Now everybody has access to this. This is a film that I won't show, but essentially you get people actually demonstrating sort of how they are doing things. The main treatment for moderate to severe Crohn's disease in Europe is a nutritional therapy, but what you have to do is actually drop a nasogastric tube every night, and for that reason we don't really do that here in the United States. But this is a video of Zach, who's 9 years old, who made a video of him. Actually, I'll show the first part. Made a video of himself. Or maybe I won't, dropping his NG tube. And every time I show it, the clinicians go, but you can see, that it may be, right? It may be useful to people to have, examples of this. I mentioned the Improved Care Now exchange, that this Pinterest-like site. This was also developed as a volunteer effort. So here are the 3 people in regular shirts who developed the ICN exchange. Here's Peter Margolis, my co-PI, who's wearing a particular shirt that was given to him by this team as a thank you note, given to us. We each got one of these from the team as a thank you for allowing them to contribute this exchange. They did all this work. They bought, they rented a GoDaddy server. They did all this, extra volunteer work, and they gave us a present. And in fact, this happens over and over again. Here's just a list of things in the last couple months that people have just come up with, and we don't tell people to do this. We don't even know that these are necessary at times, and they're just happening. And then they write us thank you cards, which is amazing. Thank you for believing in us and giving us the opportunity to work with Improved Care Now. It was amazing to do this. It's kind of an amazing thing. So I think this notion of sort of unlocking the constraints on data and the way that people interact in this, using this idea of this actor-oriented architecture is a way of creating these peer-produced learning health systems, distributed learning health systems, and we think that this is what these things can do: engage all researchers, have a measurable impact, reduce the time for knowledge generation from long time to little less time, and be a lab for new innovations and generate new evidence. And that is the end. So I have a few minutes for further conversation.
So, one of the things, so we've had a chance to do a design phase for a large-scale type 1 diabetes network, and I think one of the things that's been most impressive to me is that the things that you're talking about, Michael, are like really, they're like very simple things, right? And it's this idea that everyone theoretically should be doing it in their own center, improving care, but it's sort of the concept of the holistic way you think of the system is really important, right? So sort of this idea that everyone is coordinated, this idea that everyone is using the same marker or the same measures and has sort of like come together to decide on them. And then sort of the governance around like doing this as a collective is really important, right? Because otherwise we're sort of doing it haphazardly, maybe at Michigan, sometimes at Stanford, perhaps these other places, right? But it's sort of the overarching kind of thought about thinking of this as a holistic system has been the most powerful piece for me, right? Because otherwise we end up doing these things at the edges that don't really move the mark. Right?
Yeah, I think that's right. I mean, it kind of overcomes the NIH syndrome, right? In this case, not invented here, right? Which, we as academics, we're sort of taught, you don't want to do the same thing as everybody else. You want to develop your own niche and exploit that. So that's I'm an ear, nose, and throat surgeon. Oh yeah, what nostril? But when you start to think of the system as one system that is collective, and you're accumulating a common pool resource, you're accumulating shared knowledge and shared know-how that in service of a shared goal that you all can contribute to. It's a very powerful shift. Yeah, it's a social behavioral shift. Yeah.
Michael, most of what you shared with us today was really about engagement of these different individuals, whether they be patients, providers, caregivers, in this community. And your dashboard you showed us toward the end there was really engagement and activity within different domains. Then on your concluding slide, you said
research.
Well, I believe engagement is a valuable part of research. I also see it as a process and not an outcome. Ultimately, you're supported with grants, from your title slide, to generate improvements in health.
Yeah.
I have no doubt what you're generating here is a tremendous sense of powerful, positive, participatory feel-goodness.
Yes.
Okay, that is awesome.
Right.
And it can lead to improvements in health, I would bet. You also suggested...
We suggest that it does.
You suggest that it does. I would love to see that, yes, in some centers that aren't on improved care now, their rates of remission are lower. Or that you see this wholesale change as you see a center move on to improved care now, where more people go into remission.
Yeah.
Do you have that sort of stuff?
We do have that. It's a little hard because a lot of these places don't have population registries to start with. So the comparison data is hard to come by. But we do actually see new centers coming on, and partly this is an artifact of they enroll patients as they come in, but partly I think it's a real thing. You'll see, you saw the rate of remission increase overall, and you see the new centers coming in and going, coming up to the line. Maybe not exactly there, but so that's it's not conclusive, but it's indicative.
Well, I want to believe it. So what's the mechanism there? Is it that the docs are actually changing their practice? Is it that the patients feel empowered to navigate for themselves, be more proactive? All of the above. What's going on there?
Well, I mean, I think I would like to say honestly that it's all about patient empowerment, because that's a really cool thing. I actually think that's part of it, but my guess is that really what's going on is is that we're increasing the clinical quality of care at the start. And I mean, I'm not a practicing clinician, but I talk to clinicians, and it's not always the case that care goes the way you think it ought to, or and it's not because we don't know what to do, right? A lot of times we know what should happen. You go back and look, and it didn't happen. Why didn't it happen? Well, just work harder, right? And that doesn't work. So actually changing care to be reliably of high quality is a really hard thing to do. And so I think a lot of what happens is that the clinicians who join these new centers, they get infected with this idea of we could actually make this whole thing better, and then they're armed with some tools to do so. We teach them how to make a registry, we teach them how to populate it, we teach them how to do quality improvement, we teach them how to engage their parents and patients, and then they're surrounded by a community that also has things to offer them. They get mentorship from more senior, longer standing centers. They get to compare how they're doing with other people. They get to look around and say, wow, your rates are really high. What are you doing? Oh, here's what we're doing. So I think that is, in large part, what makes the biggest difference. I don't know really, what percent is what, but I think that is a very powerful thing. Just getting that substrate right. Yes.
So do you think that this, now that you have proven that this works for a particular community, if you're kind of extending to other communities, the same strengths and tools that you have generated would be directly applicable there? In particular, is the engagement of the community going to be different for different kinds of diseases and so on?
Yeah.
So I just wanted to pick your brains on that.
So we are right now trying to replicate this, Joyce mentioned, in cystic fibrosis and type 1 diabetes. There's this, the old 80-20 rule, the Schuhart rule of is probably 80% the same and probably 20% different. I think we're kind of starting with that proposition that the tools themselves probably will work. They'll need a little bit of tweaking for the different communities. There are a lot of similarities across conditions, but there is also, of course, differences. I mean, type 1 diabetes is relentless. Right? Crohn's disease is a bad deal, but you take your pills, you get your TPN or whatever, and you do your surgery, and it's not like every single hour or minute you're doing this adjustment on the fly with your blood glucose. Cystic fibrosis also has its own dynamics, right? There's this loud ticking noise. It's the clock. And so that engenders sort of different dynamics in the community and the patients and physicians. The other thing about CF is that the kids can't be near each other for fear of cross contamination. So a lot of the stuff that we're doing, this picture of these 4 kids, that would never happen in cystic fibrosis. So there's differences, but I think that structurally from at the level of the architecture, I think it's very, very similar. At the level of the tools, I think it's mostly similar. And then at the level of the individuals, it's probably similar enough. But that's what we're trying to find out. Yeah.
The last thing I want to say was that I've been remarkably impressed with this idea of it really just being a human system rather than a technology-driven system. Right? So I think with EMR and multi-technology and all these things that can make care better and outcomes better,
those are all important.
but it's really the human architecture that's leading or driving the change, right? Because the technology employed it's not groundbreaking.
It's not new technology. It's Pinterest.
Yeah, I mean it's actually it's pretty simple.
Mm-hmm.
Right? So it's really about it's the people architecture.
I think that's right. I mean, ultimately, the healthcare system it's like Soylent Green, right? It's made out of people,
So I think, so if you feel good, so coming back to your point, right? I mean, that is probably already half the battle won, so to say. So maybe that is what is showing up here because of the collaboration and the community coming together.
Yeah.
But there is also the care aspect of it, and
Yeah.
probably what is appearing is the care also improves, or the perceived care improves.
Well, I think it's both perceived and actual. I think that, yeah, I think that's exactly right. But I think you're right, Matt, that it is a feel-good thing. But I actually, I think that's not really the important part. It is an important part, but that's not the end of the story. I think
It ensures engagement.
what that, I think that what that does is it allows people to, first of all, be more resilient in the face of this system. The healthcare system is pretty toxic, not only to patients but also to clinicians. It's hard work, and it's really hard to do the right thing in the healthcare system. I think you need a lot of resilience to enter into this system, and so having some of that resilience is useful. I think it also allows people a little bit more creativity. So, if this is not working, well, I'll just give up, or whatever. But maybe you'll try something new. And it also, I think, that creativity then might be combined with better ways of, better systems for actually getting some of the work done, which might be helpful as well. So I think it all kind of, is together.
All right.
All right.
Thanks, Mike.
Thank you.